Estimate the endotracheal tube size needed by palpating the cervical trachea, as shown here. Have several tubes of varying sizes available and inflate the cuffs to check for any leaks. Next, deflate the cuffs and lubricate to the end of the selected tube with a sterile lubricant or lidocaine gel. Once the patient has been properly sedated, place him or her in sternal recumbency. We will begin by discussing the procedure for two-person intubation. An animal and lateral or sternal recumbency will usually require 2 people to intubate. An assistant supports and extends the patient's head and neck, then opens the mouth with one hand by placing the finger and thumb behind the maxillary canine teeth. The assistant's other hand pulls the tongue forward and against the mandible using a 4x4 gauze. Care must be taken to avoid pulling the tongue down onto the canine teeth and puncturing the ventral aspect of the tongue. The assistant must also avoid placing pressure under the patient's neck and obstructing the view of the larynx. The technician should now gently insert the laryngoscope blade into the oral cavity. Hold the blade against the tongue and use the tip of the blade to open the epiglottis and expose the laryngeal folds as shown here. If a laryngoscope is not available, the tube can be used to depress the tongue and visualize the laryngeal folds. For single-person intubation, the patient is placed in dorsal recumbency with the head and neck extended forward. Dorsal recumbency positioning reduces excessive manipulation of the head and neck during intubation of the traumatized, critically ill, or unconscious patient. With your dominant hand, hold the tongue and laryngoscope handle, with the handle pointing up. Use the tip of the blade to open the epiglottis and expose the laryngeal folds. Once the cords are visible, insert the lubricated endotracheal tube through the cords and into the trachea until the cuff is at least 1 to 2 inches past the laryngeal folds. Cats can have significant laryngeal spasms that prevent passage through the laryngeal folds, in which case it may be necessary to spray a small amount of lidocaine onto the laryngeal folds. A stylet or guide tube placed into the endotracheal tube may also be used to gently assist passage of the small tube through the narrow passageway. Make sure there is at least 1 inch of stylet at the back end of the endotracheal tube to facilitate removal, and that the tip of the stylet is not exposed at the other end of the tube to prevent trauma to the laryngeal folds and trachea. Remove the stylet once the end of the endotracheal tube passes between the laryngeal folds. After the endotracheal tube has been placed, secure the tube with tie gauze or tubing behind the canine teeth and around the maxilla, mandible, or neck. Next, incrementally inflate the cuff with 1 to 5 cc of air. With each incremental injection of air into the cuff, check for air leaks around the cuff by delivering a breath while listening and lightly smelling for gas at the mouth. Be sure to confirm that the chest inflates with each breath delivered. Using a stethoscope, auscult both lung fields while squeezing the bag to confirm that breath sounds are heard bilaterally. If breath sounds are not heard or abdominal distension is observed, intubation of the esophagus and not the trachea is likely to have occurred. If the tube is not in, remove the tube. At this time, it is best to examine the laryngeal folds and make sure that the tube is in the trachea. Breath sounds heard on one side of the chest suggest that the endotracheal tube may be placed beyond the trachea into one of the 2 main bronchus. If this occurs, deflate the cuff and slowly retract the tube until breath sounds are ausculted on both sides of the chest, and then reinflate the cuff.